This is actually at one of our outpatient clinics. It's referred to as the Alter G. Anybody seen this? So you can see that this guy has, this is the top end of this rubber bladder that the patient has to wear. So it looks like these really weird biking shorts that are made out of rubber that have a big flare at the top that has a zipper around it. And so after the patient dons some of the shorts, they actually get zipped into this thing. And it's an airtight seal so that, that you can get the pressure inside of this airtight chamber high enough that it actually simulates an anti-gravity state. And so the patients can practice walking on a treadmill, running on a treadmill. They can even be put into this device so that they might do steps sideways if they want to work on an activity like that. And so this is a device that we've used it with a lot of the orthopedic populations, but I think it also holds great promise for working with populations that have neurological conditions that affect gait. And so this is another device that I haven't quite kicked off any research projects with, but would be another technology that would be good to see if we could train people with this type of device. Balance is not compromised because they're basically held inside of this. And you can see that there's actually a screen right here that the individual can receive concurrent feedback about what the legs are doing while they're inside of this device. So if that is a goal of therapy, to teach the patient about where the legs are in space as they're ambulating, then they're able to receive that feedback. Because all of these systems that compress the lower legs, you know, a good example is if you think back to the first technology I showed you, the Locomat. You've got this harness system that is holding body weight, and that means that you're going to compromise some of the venous return. And so there have been studies that have been done with the Locomat to show that it does not push the blood pressure dangerously high, although it does elevate blood pressure. It would be the same thing with this, that it is something that you have to think about. I haven't seen any studies that look at blood pressure changes with the Alter G, but I would have no doubt that it's influenced. The thing that would be altered here is how much gravity you're removing. And so if you were going to train someone, let's say that they were detrained because they might have a condition like Charcot-Marie tooth. Have you ever heard of that before? So that's a heritable neuropathy where a person's nervous system basically produces too much myelin, and that begins to slow down the conduction of impulses through the neurons. And so with somebody like that, they as they age into the disease, they become more and more deconditioned. And so if you're going to train somebody that might have Charcot-Marie tooth, then you would probably want to start off with a high body weight support so that they were bearing very little of their weight. And as they became more trained, you would begin to progressively increase the amount of body weight that they were supporting. So that would be, by intention, the way that you would use a device like this. This is something that it's not quite installed yet, but it's on the way. It's a zero-G gait and balance system. So it's basically a harness system that has a torque motor in it to help arrest the line that comes out of it if the person loses their balance. The only trick with it is that you have to have a trackway that the whole system runs on. So we have to have a space devoted in one of our gyms to be able to mount this to the ceiling and then make sure that we can have a clear runway for the patient to be able to wear this system and practice walking, basically. So this would be a transitional type of device. After an individual might work with the Locomat, then they would begin to transition to more overground walking, but with assistance, so that you don't have the poor therapist back here having to arrest a fall if the person starts to lose balance. So that's another system that's on its way. Here's another system that is beginning to look at dysphagia, which is basically a swallowing disorder, very common after a stroke or a brain injury. And anybody had any grandparents that have had a stroke? Have you? Did they have swallowing problems afterwards? Depending upon how close he is to the stroke, may or may not have had swallowing issues, but it's a very common impairment after a stroke. And so the way that we approach it at St. Luke's is that we have to modify the foods. If it's severe enough that we don't want to put any food into basically the same anatomy that you have to take breaths through, then they might have to receive feeding through a tube, either an NG tube or a PEG tube that puts nutrients directly into the stomach. But if they begin to recover, then we will modify the food, so they might have foods that are all pureed. You know, it's like having a whole bunch of milkshakes or shakes made out of whatever it is that might be on the menu for that day. This is a system that uses electrical impulses to try to help an individual recover swallowing capability. And so our speech therapists love this system. They think it has high success rates with being able to help an individual retrain capability to swallow. And if you don't regain that capability, then you're always at risk of aspiration. And on the other side of aspiration, what do you think happens? What do you think is the worst outcome from aspiration? Well, die, yeah, but most people usually don't die from aspiration. It's pneumonia. And so it usually induces an infection in the lungs. And that's what will get somebody instead of choking to death. And so we pay really close attention to doing dysphagia screenings for patients that have had some type of brain injury, stroke, or from trauma, to make sure that they don't have any swallowing issues. Okay, a little bit about research at St. Luke's. We have two kind of broad classes of research that we conduct at St. Luke's. We have industry-sponsored, which are going to be drug trials. So we have 4 drug trials that are going on right now. 3 of them are actually in Charcot-Marie-Tooth, that condition I mentioned just a few minutes ago. And then we have one that we just started in ALS. And so we have patients that we recruit from our clinical practices to come in for these particular studies. But then we also have investigator-initiated studies. And so these would be studies that we don't have an industry sponsor that is basically designing the protocol for us. Instead, we design the whole study. So the types of things that you all would do would be investigator-initiated studies. And so to try to make sure we keep somewhat of a balanced portfolio, we try to have some industry sponsored, and we will always have some investigator initiated studies that we would do. So,
Doug, I'm just curious, what are the base rates for those disorders that you're doing the clinical trials in? ALS and the Charcot-Marie-Tooth.
So the
base rates, like how many people do you guys see that?
With Charcot-Marie-Tooth, we have a population of about 40 patients.
Wow.
Yeah, because it's heritable, once you find someone in a family that has it, you usually have familial links, so that we might be seeing a whole family of individuals that have the same conditions. With ALS, it's the prevalence of ALS is increasing, and there are not a lot of clinics that want to see ALS patients. And so we probably see about 25 ALS patients, but there are other clinics in Spokane that we work very closely with that also see about that same number of people. So here's a couple of technologies that we've employed in various studies at St. Luke's. Here's the shimmer right here. So think way back to St. Luke's community, and I pointed out that nice soft leather chair that was the beginning point for a task that we would have patients perform. We had them wearing shimmers, one on each ankle and then one on the lower back. And we're collecting data on kind of a timed up and go task. You guys are familiar with the timed up and go, right? We modified it a little bit so that there was a vehicle transfer into and out of that white SUV that you saw in the outdoor portion of St. Luke's Community, and then they head back and sit down in the nice leather chair. We have, with some of Diane's group, we've been conducting studies with Fitbits. We've kind of not been collecting data over the last couple of semesters on that, but I think we're about ready to start getting that up and going again. Fitbits, actually any of these devices that count steps. I see this study over here that looked at different types of devices, a shopping cart, cane, walkers, and how accurate step counts are when you know ground truth by being able to count the number of steps an individual takes. So this is a study that we have going on right now where we're beginning to look at sleep and how disordered it gets after something like a stroke or a brain injury. And so what we're doing in this study is randomizing patients to receive either blue light in the morning or red light in the morning. And if you think back to your old physics high school class about the visual light spectrum, Roy G. Biv, remember that? You got blue on one end and red on the other, so that's why I chose red as our control condition. And so in this particular study, we're seeing really promising effects on cognition and sleep when they are exposed to blue light in the morning. We're not seeing the same influences when they're exposed to red light, the control condition, in the morning. The next step on this is that I want to have the patients, we're trying to turn off melatonin production in the morning, but I also want to see if we can induce melatonin production at night. And so the next step in this, we've kind of halted data collection so we can get a grant proposal put together, is to start having patients wear orange goggles at night. So how many of you use orange glasses at night so that you're not exposed to blue light? Nobody? Better get your iPhone set so they have that kind of that setting. Okay, and you need to think about how much exposure you're getting to blue light. All the devices that we use at night are going to expose us to levels of blue light that actually don't let melatonin production get underway. And so you want to be real careful about that. And I think we're probably at a point where